Welcome, everyone. Thank you for joining. We're going to hop right into it. We're going to do some test taking, and hopefully this is really, really helpful for you guys because it's going to cover some stuff that I struggled with personally as a med student, and some of it may be easy, some of it may be hard, but we're going to try and dissect into what's really going to be high yield and get you easy points on your test. So, a 68-year-old man presents with acute onset right arm weakness and facial droop. His medical history is significant for hypertension. On physical exam, the physician notes hemiparesis and decreased sensation of the right upper extremity and his lower face. The patient has normal cardiac auscultation, except for an irregular rhythm with a rate of about 130 beats per minute. Serum troponin is normal. The EKG is shown. A thromboembolic event is suspected. All right. So, anytime you see an EKG question and they give you an EKG in the question stem, obviously, you're going to need that, or at least it will be a heavily supporting factor to help you answer it. So from which of the following structures did the embolized thrombus most likely originate? You can solve this question in honestly about 15 seconds if you know 2 or 3 facts. So what I would do is going back through our usual method of operations here. So you're looking for a structure. So that's going to be your intention. So you're thinking about a part of the body. And so with this patient, they have a stroke, all right? They're gonna have hemiparesis, decreased sensation, so it sounds really like a stroke. Anything that's unilateral deficits, one of the top differential diagnoses for you is gonna be stroke. He has an irregular rhythm, which you don't even need the question stem to tell you that. That actually just makes this question too easy for you on your actual boards, because if you look at this EKG, you can actually see that it's irregular if you are gonna monitor the difference between the RR intervals here. Okay, so if this patient has an emboli and they have an irregular rhythm, this is a dead giveaway for AFib. So atrial fibrillation. Anytime you see the phrase irregular, this has to be basically your answer for step 1 and step 2. And so if you look, there's no like really great discernible P waves here. That's another characteristic of AFib. And so be careful, because sometimes you'll see one, sometimes you won't, but they're not uniform throughout the EKG. And the easiest thing here is to look at the RR interval. This is exactly how I dissect these EKGs, is I look at the RR interval and see that it's different lengths between each heartbeat. And so if you see no P waves, and you see that RR interval is different, you got your diagnosis of AFib. And a lot of people really struggle with EKG questions. But to be honest with you, especially in an acute patient in the hospital, the first thing I look for on their EKG is actually AFib. Somebody comes in with chest pain, they feel like their heart is racing, their heart rate's in the hundreds. I basically jump to AFib because we see it so often in post-operative patients as a complication of anesthesia, or especially in cardiothoracic patients if they have manipulation of their heart. So this is a fact you have to know. So if you can diagnose it as AFib, you know the answer. It's going to be C, left atrial appendage. And so if here's your heart, obviously it doesn't look quite like this, but there's basically a little appendage here at your left atrium. And what happens here is with AFib, your heart is beating like erratically, right? And so it doesn't allow the heart to squeeze the blood in and squeeze it out. So your systole and your diastole is erratic and it's not uniform. And so the blood can start to swirl and get stagnant in this left atrial appendage. And so what happens is now you have thrombus that can build up. And so in a patient with AFib, it's obviously the atria that are fibrillating. And so it's the atria that you want to look for the thrombus. So using that knowledge, you can cross off the left ventricular apex, because it doesn't make sense for the thrombus to come from the ventricle if it's atrial fibrillation. So left ventricular apex is important though, because you can see an LV thrombus, so left ventricular thrombus, after an MI. So if this patient had ST segment elevations, so let's just redraw the EKG and let's just say it looked like this instead, or this right here, it looked like this. So if you had that ST elevation and it wasn't irregularly irregular, let's just say it was completely uniform RR intervals, then your answer would actually be the left ventricular apex. So this is kind of what I want to do with this question here, is because this question in and of itself is easy if you know the basic facts for it, but we're going to try and figure out how you could get to other EKG findings based upon some of the information that we can discern. So that's what you would look for in an EKG, and the answer would be LV thrombus after a heart attack. And so we see this all the time. This is actually something that's a pretty big deal in vascular surgery because it puts a lot of our procedures in jeopardy. So we're always looking out for that LV thrombus. Okay, next thing that I want to talk about is this patient that had the left atrial appendage thrombus that embolized. Where did it actually go? Well, if you look at the symptoms, they have right arm weakness and facial droop. So that's going to tell me that this patient had a stroke to their MCA most likely. So this is a MCA stroke, that middle cerebral artery. Because remember, your middle cerebral artery, that's going to supply your upper extremity as well as part of your face. And so if it was an anterior cerebral artery stroke, that would be more legs. So an MCA stroke, I'm going to just put here in orange, that's going to be head into upper extremity. This is just in broad terms, obviously. But then for, let's just say it went to an ACA stroke, that would be more lower extremity involvement. And I drew it going downwards to help remind you, if you have a visual memory, that it's going to the lower extremities. But obviously your ACA is up in the brain as well. So MCA and ACA are in the brain, but the ACA, I just drew the emboli going downwards towards your lower extremities. And this is not really a great mnemonic by any means. I try and come up with better ones than this, but I remember ACA starts with ants, and ants are on the ground. So it's your lower extremities that get affected with an ACA stroke. So like I said, it's not that great of a mnemonic, but sometimes just hearing something weird like that can help stuff stick for you. Okay, next thing. B, deep leg veins. So this is a really easy answer choice to rule out, because a thrombus from your deep leg veins is not going to affect your EKG findings at all. So this would have really no EKG findings would help you with this answer. And so maybe the patient has incidental EKG findings, but in terms of a UWorld question or your USMLE itself, they're not going to give you an aberrant EKG and not expect you to use it. Like, that's meant for you to use. In the hospital, obviously, you can see people that have all kinds of underlying issues going on, but in an actual test-taking scenario, you need to use the EKGs if you're given it. That's a test-taking tip for you for today, because a lot of people, they might think, well, is this really correlated? The answer is, for EKGs at least, it's almost always. If they give you a finding, use it. And so a deep leg vein, that would be considered like a DVT. So if you've heard the term DVT, deep venous thrombosis, you can actually still get strokes from a DVT. Like, it can embolize from your legs, and it can go through a PFO. So if this goes through a PFO in your heart, so that's a patent frame and ovale. I actually had a friend that was in the hospital as of this morning who had a PFO and actually got a stroke in the last 24 to 48 hours. So what it is it's basically a little hole in your heart. The clot can go through there. It can actually get up to your brain. So you can actually get a stroke from a DVT. But usually what happens? Well, a DVT is usually going to cause a PE, so a pulmonary embolism. Because let's talk about it. If you have a DVT in your leg, so let me just add on a page here. So if here's your leg, and you have, let's just say, a clot right here. It's going to be in your deep venous system. If it embolizes upwards, and here's your heart, once it gets into your heart here, it's going to go into your right atrium. It's going to go past your tricuspid valve, and it's going to get into your right ventricle. So here's your RV. From your right ventricle, it's going to go into your pulmonary vasculature, and it's going to get to your lungs. So it's going to keep going, keep going, keep going, past your pulmonic valve, into your pulmonary artery, into your lungs. And so it's going to cause a clot in your lungs. And so this is called a pulmonary embolism. And just to recap what I had said about a patent foramen ovale is, remember, if you have a clot in your leg, so like a DVT, and the DVT goes up to your heart, and once it gets to your heart, it actually goes through your PFO, your patent foramen ovale, then it can actually embolize up to your brain and cause a stroke. So those are really some high yield things to know that oftentimes, especially M1s and M2s, get confused, but even M3s studying for your shelf exams, if you never solidified that information as a step 1 question, then it can still get you on step 2. So what are some risk factors for DVTs? So let's just talk about that real quick. So how do you even get a DVT? Well, number 1 is going to be like immobility. So somebody that's not really walking around a lot. So this would be like a post-surgical patient. So somebody that is basically immobilized, they're laying in bed all the time, and they get a clot in their leg from stasis. So if you think back to Virchow's triad, stasis is going to be one of the big risk factors for causing a thrombotic event. Okay. And so where does DVT most commonly come from? Well, obviously from the lower extremities. You can get DVTs that embolize upwards, anywhere from like your iliacs, your femorals, your popliteals. And so that's really one of the big problems. A misconception that a lot of people have is they think that a pulmonary embolism can only be caused by a DVT, because that's what you classically learn in classes. It's not actually true. So I'm going to list some of the alternative causes. So also can be caused by, so number 1 could be a fat embolism. And so where would you see a fat embolism? That'd be like after you fractured a long bone. So this is oftentimes after femur fractures. So you need to know that for your surgery shelf exam. Femur fractures. Because there's a lot of fat in the femur bone, like in the bone marrow. And when you fracture it, that fat can actually leave and get into your vasculature and embolize upwards and cause PE. So definitely you want to look out for the fat emboli. Another thing is with pregnant patients, you can actually get it from amniotic fluid. So you can get amniotic emboli. And those are like really the major ones. So DVT, fat emboli, and amniotic emboli. So whenever you have somebody with a PE, what really happens? So let me draw a little arrow over here. So PE, and we're going to discuss some of the pathophys. And so what happens is you end up getting hypoxemia because you're blocking off the blood flow to the lungs. And then that's going to result in pulmonary vasoconstriction. And this is hyper important for step 1. This is something that I remember missing on a practice question once, is what happens systemically when you have hypoxemia or hypoxia? You usually dilate to deliver more blood there and basically be able to replenish the low oxygen state. The lungs, they're unique. So I'm going to underline this like 7 times for you because this is a verified test question. So the lungs, whenever you have hypoxemia or hypoxia, they're going to constrict. And the way I remember this is once the lungs already don't have oxygen, they basically say, screw this section of the lung that's not working, and we're going to maximize the rest of it. And so what happens here is, like, let's just say you have a clot over here in your lungs. So all around this would be like vasoconstricted down because your lung's just going to try and fix the VQ mismatch. So you vasoconstrict to try to fix the VQ mismatch that you get, your ventilation perfusion mismatch that you can get from a pulmonary embolism. And so that's super, super important because now, like, you could get a question, and this could be tied into step 1 or step 2. They could tie this into an ICU question for step 2, and they could also just give you a pure physio question for step 1, asking the exact same thing. And so what happens is now you have increased pulmonary vascular resistance because you're constricting, right? So anytime you constrict vasculature, you increase the resistance in that vessel. And so now, if you have increased pulmonary vascular resistance, it's harder on the heart. And so that's going to result in you decreasing your right ventricle stroke volume. So there's all kinds of pathophys that they can ask you about a pulmonary embolism. So you throw a clot, now the lungs, they're unique. So they vasoconstrict and say, screw this area of the lung. So now you increase the resistance, which makes it harder for your blood to stroke out of your right ventricle. So think about your right ventricle fighting against the force of this increased resistance. Okay, so now you're gonna work your right ventricle much harder. So your O2 demand goes up, so your oxygen demand increases. This is kind of just common sense. You don't necessarily need to write that because anytime that the heart muscle itself would work harder, obviously it's gonna need more oxygen. It can cause even concentric hypertrophy of the of the right ventricle if it's long-term. So you can get concentric hypertrophy. And an easy way to tell if something's eccentric or concentric is if it's squeezing repeatedly. Like if you think of a muscle, for example, like let's just say your biceps. If you squeeze your biceps repeatedly, I think of that as like a concentric motion, right? And it's the same thing with your heart. You can get concentric hypertrophy when your heart squeezes repeatedly. Eccentric hypertrophy is usually from a dilation of overflow of volume. So it's like, think of the eccentric, like stretching it out like a rubber band. So concentric hypertrophy of the heart looks like this. So that's concentric. Whereas eccentric would be like stretching it out like a rubber band. And so eccentric is usually from overload of volume situations. And then concentric is like from increased work. So you have increased work, AKA the high oxygen demand. The right ventricle is working super hard, causes concentric hypertrophy. And so really the big thing to know here is they can also ask you which of the following things would be seen with a PE, and it's a VQ mismatch. And so I know that these terms can get kind of confusing if you're M1 or M2. So just keep in your back of your mind that all this stuff that I'm talking about with the lungs is a pulmonary embolism. If I'm talking about a clot in the leg, that's a DVT, so deep venous thrombosis. So how do you even diagnose a PE? And I know we've gotten off the EKG train a little bit here, but I like the direction this is going, so I'm going to just talk about it for a little bit. So you diagnose a PE with a CT scan. And so you usually get like a CT angiogram of the chest. Okay. And so this is going to have like a 90 to a 95% sensitivity and specificity, meaning it's a really good test for diagnosing a PE. They used to do stuff like a VQ scan. So this is the old way. So it's a ventilation perfusion scan, because if you remember, I said that there's a VQ mismatch. So you could see this on a VQ scan. You really only do this for patients now that are, if they're pregnant, because you don't want to give them the contrast from a CTA, or if they have really bad end-stage renal disease, because then they can't get contrast either. Okay, so those are like really just because of contraindications. Something to know, you don't necessarily need to know this for your boards, but just for real life, is you don't want to give your contrast for a CTA if your GFR is less than 30 to 35. And so if somebody has poor kidney function, the contrast can further precipitate renal failure. And obviously you don't want to give a pregnant woman contrast. That would be muy mal for the fetus. Okay, so if a patient has a PE, what would their EKG look like? And that's why I wanted to kind of tie all this together. So their EKG is going to be sinus tachycardia. And this is really important because a patient that has a PE, they're generally in a question stem going to give you sinus tachycardia. Rarely you'll see that they may have something like AFib. The classic thing that they'll throw at you on step 1 and step 2 is S1, Q3, T3. I've seen this in 1 or 2 practice questions over the years. And so what happens is you get an S wave in lead 1, so that's why it says S1. You get a Q wave and an inverted T wave in lead 3. And so this is something that is almost impossible for somebody that's just beginning to interpret EKGs to find on an EKG. So you're going to have to use the clinical history to help you. But I did see a question where it actually asked which of the following would be seen, and this was an answer. The answer was like an S wave in lead 1 and a T wave inversion in lead 3. So that's how you got to the diagnosis of PE in a high level question. But that's one that maybe around 10 to 15% of students are going to get correct. So just know that in the back of your mind if you're going for the 260 to 270 range score. But if you're just beginning with your EKG journey, then that's something that's a little bit lower yield for you right now. Okay, and so what do you expect this patient's ABG to show? So we're going to take this like full in here into what you would see in the hospital. Excuse me for 1 second. Sorry about that. Okay, so what would you see on the ABG for this patient? Well, you're going to see, because of their tachypnea, you're going to see respiratory alkalosis. This is super high yield for step 1 and step 2, is knowing respiratory alkalosis is associated with a pulmonary embolism. And the reason is because of the tachypnea. So you have to assume that they're tachypnic with a PE, because if they have a symptomatic PE, think about it. They're throwing a clot to their lungs. The clot is going to make it so it's harder to get oxygen. So they have hypoxemia. They have pulmonary vasoconstriction. And to compensate for all this, to actually try and push enough oxygen into their bloodstream from their lungs, they're going to have to increase their respiratory rate. So they get tachypnic. So this is an increased respiratory rate. Let's just say over 20 or over 22 or so. So if you see anything higher than that, you know that they're tachypnic. And so these patients oftentimes will have an increased AA gradient. So their alveolar arterial gradient. So you can actually just take the numbers if they give them to you. So their alveoli minus their arterial gradient. This may be increased, maybe like 15 or 20 or something around there in a patient with a PE. But the major thing you need to know for boards is respiratory alkalosis. Something I haven't mentioned yet that I do want to point out, because I've also seen this as a PIMP question in the hospital, is what is another high yield thing that you could see on your EKG? And this would actually be a right ventricular strain. So make sure you know that you can see a right ventricular strain, because they will often tell you this in the question stem. So you might not have to diagnose it from the EKG on your test. In fact, it's fairly rare that you'll have to actually rely on that to solve the question. But they could say, patient got an EKG, shows sinus tachycardia with right ventricular strain, boom. The reason why there's an RV strain, instead of just memorizing this, you want to think, what's working hard? We'll go back to our picture up here. There's increased pulmonary vascular resistance. So there's low right ventricular stroke volume, meaning you can't get a lot of blood out. So your right ventricle has to work harder, right? So you have that concentric hypertrophy. And since it's straining, you can actually see that on the EKG. So use your logic to work through this rather than memorizing it. Sometimes you guys will hear like D-dimers thrown around with pulmonary emboli. D-dimer is kind of a fairly non-useful test, just because its sensitivity is good, but the specificity is so poor. And so this is something to know, is it has really poor specificity, but high sensitivity. And you should actually know that about D-dimer. And it's one thing that you kind of learn about as a med student. And then when you get in the hospital, a lot of surgical teams will not even order D-dimers just because it's not really necessary. But a lot of the medicine teams do order it. The only problem is basically every surgical patient is going to have elevated D-dimer just due to their inflammation and their acute stress to their system. As well as if you're like pregnant or you have any kind of other pathophys going on, your D-dimer will be elevated for basically anything. So you can't rely on it to help you diagnose the PE really. It's only used just for sensitivity issues, if you would like to throw that out there. So those are like really my major points about a PE. So let's talk about treating them real quick. Well, the treatment is going to be anticoagulation. I'm not talking about like antiplatelet. Like I'm not saying aspirin or clopidogrel or ticagrelor or anything like that. I'm saying like actual anticoagulation. And so some of the best things that you can use would be heparin. So you put them on a heparin drip. That's usually like pretty much one of your first things that you would do. So we use unfractionated heparin. The thing that you track with unfractionated heparin is going to be your PTT. This is like every vascular surgeon's best friend. Like we measure PTTs 4 times a day for our patients on heparin drips. And so you do it like 4 a.m., 10 a.m., 4 p.m., 10 p.m. every single day for patients on heparin drips. And then you titrate the drip accordingly to make sure that they're therapeutically anticoagulated. So just for the sake of me teaching this lecture, please never miss this question on the PTT. So what else can you do? Well, you can also do enoxaparin. Enoxaparin, a good TQ to know is you want to avoid an end-stage renal disease. So if anybody has a low GFR, you don't want to use enoxaparin. That's a really good TQ to know, because a lot of teams in the hospital like to use enoxaparin rather than heparin because you don't have to titrate it. But the reason why we use heparin is because almost all of our patients have some form of kidney disease, being that they're vasculopaths. And so that's why we use the unfractionated heparin for basically all of our patients. But enoxaparin is just way more convenient because you can just administer it and not have to track like a PTT level or anything like that. Longer term, you can use like a DOAC, or you can give warfarin. Those are kind of some other options. So you can use like warfarin or apixaban. Basically anything that's a strong anticoagulant. If the patient comes in and they're hemodynamically unstable, then you might want to take them to surgery. So this is more of a step 2 question. So if they're hemodynamically unstable, so what's that mean? That means low blood pressure and high heart rate. So you could take them for either thrombolysis, or you can do an embolectomy. So the names really tell you what's going on here. Embolectomy, you literally are pulling out the clot. Thrombolysis, you're lysing the clot with a thrombolytic agent. So like alteplase or something like that. So I'll just put alteplase as one example, but just know that there's others. And then an embolectomy is something that you would do with wires and catheters, and you basically go in there and pull out the clot. All right, that is going to get you most of the stuff on a PE. And I know we kind of got way down the rabbit hole, but I wanted to touch on that because there's a lot of high yield information here. So all this started because deep leg veins was an answer choice. And so we talked about the EKG findings. We said that there's going to be sinus tachycardia. You would also have that S1Q3T3. And then also you could have that right ventricular strain with pulmonary embolism. And so if it's just a plain old DVT, however, there's not going to be any EKG findings. So that's something important to keep in mind, because remember, if it's just a plain old DVT, then there's like really nothing that's even affecting your heart at that point. It's only whenever it becomes a PE would you have the EKG findings. All right, next let's look at a cavernous sinus. So cavernous sinus is an interesting answer choice here. You don't see that as a lot of USMLE questions because there's not a whole lot of things that they can ask about it. In terms of, for neurology questions, if you have to take the neurology shelf, you should know about cavernous sinus thrombosis, however. And so this is usually from an infection. So this is usually associated with infection. Okay, and so you have like the triangle of death, which is around your nose. So like, let's just say, here's your nose. And that's a bad nose. But if you get acne anywhere within this triangle around your nose and you pick it and it gets into your bloodstream, it can actually get straight into your cavernous sinuses really quickly. And so that area in your face is actually valveless venous vessels. And so there's like no valves in these veins. And so that allows the infection to spread contiguously really quickly into your cavernous sinus. And so anywhere like your nose, your sinuses, even like your maxillary teeth. So I'll just even put some teeth in here for you to remind you that you can get cavernous sinus thrombosis from infections from your teeth. That's a little bit lower yield. The more important one is to know around your nose. That infection can get into your bloodstream, spread through the valveless venous system. Okay, what would be the bacteria that causes this? Well, the answer is going to be Staph aureus. So this is usually Staph aureus. And so it's just a normal skin flora. Obviously, other stuff can cause it, but this is going to be 3/4 of them easily. So if you don't get treated for cavernous sinus thrombosis, you have like a 1 in 3 chance of dying. It's pretty high mortality if it's not treated. But obviously, if it's caused by an infection, then you know you're going to want to give antibiotics for these patients. And so what happens is the cranial nerves that go through your cavernous sinus can all be affected with this cavernous sinus infection. And so the things that you often see is these patients will like lose all their motor function to their eyes. So they might actually just have their eyes kind of stationary and locked. And so that's because like all of those cranial nerves run through your cavernous sinus. So here's going to be one of your things for homework today. So look up the cranial nerves in the cavernous sinus. And so kind of a fun fact about the cavernous sinus is it's the only place really in your body that an artery runs through a venous plexus and of the same nature of like a sinus. And so your internal carotid artery actually just goes right up through there. And so obviously you diagnose these patients with a CT or an MRI with contrast so you can see what's going on. Treat them with antibiotics, and that usually helps your prognosis pretty well. Some people will tell you to give heparin for this. I haven't seen a lot of good data on it to treat the cavernous sinus thrombosis. Even though it's a thrombotic event, it's usually caused by the infection. So anticoagulation is not strongly suggested. It's really a B or a C grade recommendation. So that's really the major things I would know about cavernous sinus thrombosis. Okay, and lastly, let's talk about this mitral valve here. So the mitral valve, if you have vegetations on it, you might have Liebman's, Sachs, endocarditis. And so the easiest way to remember this, and I'll just write it out for anybody that's just now hearing about this. So Liebman, Sachs, endocarditis. So the thing that's really interesting about this is the mnemonic itself. So I remember LSE is associated with SLE, so systemic lupus erythematous. And so you kind of just like switch the letters around, and it helps you remember that mnemonic that it's associated with lupus. And that will get you a question or two for sure, because it's easy whenever you start hearing all these different autoimmune diseases to forget which ones go with which disease and which symptoms. So those vegetations, another way to remember it is if you look at our little mnemonic here, the LSE and the SLE, they're kind of like mirror images of themselves, right? And so if here's your mitral valve, let's just say this little circle is your mitral valve, you actually get these Liebman, Sachs, endocarditis on both sides of the valve. So you need to know that it's on both sides of the valve. And so this is going to actually really help you is if you see a question stem that there's going to be vegetations on both sides of the valve, Liebman, Sachs, endocarditis should be one of your top differential diagnoses. In fact, I almost always jump straight to that if I see a question that even partially mentions that there is vegetations on both sides. My radar immediately goes off looking for other things associated with lupus. Okay, so that's how I would diagnose and dissect A, B, C, D, and E.